Good morning. Welcome to the first session of the conference. And to start this, we have the plenary session by Dr. Emmett Wong, who's a consultant at the National University Hospital at Singapore. Dr. Emmett Wong obtained his medical degree from the Wong Lo Lin School of Medicine at the NUS in 2012. He is trained in nephrology, and besides nephrology, he has a keen interest in kidney transplantation, and particularly in transplant immunology, HLA, eplets, and rejection. He is also an adjunct assistant professor in the Department of Medicine, Yong Lo Lin School of Medicine at the NUS. So Dr. Emmett Wong will be speaking on optimizing transplant immunology in resource-limited settings, balancing precision and practicality. So over to you, Dr. Yong.
Thank you for the very kind introduction, and a very good morning to everybody. It has been a very wonderful inauguration ceremony last night, so hope that everybody will enjoy the talks today. And so thank you for the kind invitation to speak on this topic, optimizing transplant immunology in resource-limited settings and balancing precision and practicality. So I think just by way of introduction, a very brief overview on histocompatibility again. So the human immune system has evolved as a highly sophisticated defense system that functions to distinguish between self and non-self. And from an evolutionary perspective, this was essential to survive attacks by pathogens. But of course, there will be inconvenient penalties such as occasional reactivity to self, like autoimmunity, and reactivity to genetically disparate members of the species, such as alloreactivity. And this later phenomenon came to light when pioneers attempted to transplant organs between unidentical pairs. Sorry. Okay, so we can look at the evolution of how histocompatibility took on, and from the evolution of how MH, the major histocompatibility complex, was discovered, and to the HLA-A2, and subsequently the inauguration of the MHC workshops over the years. And it was found that really the main determinant and the most polymorphic part of the human genome is actually that of the MHC gene, which is first defined on blood leukocytes on chromosome 6. And it encodes cell surface antigens presenting proteins with more than 200 genes that are responsible for regulation of the immune system in humans, with both class 1 and class 2. As you can see, number of alleles only serve to increase over the years, with now more than 1,000 both class 1 and class 2 alleles that are known. And at the same time, this is where the HLA region is on chromosome 6. What's probably more clinically relevant at this point is class 1 and class 2. And loci specifically ABC for class 1 and DR, DP, and DQ for class 2. Now, I think more importantly, the big picture really is why we need to get it right from the get-go, and this is where precision is important. Right. From the outset, I think even very early on in the early 2009 and subsequently in 2012, we can see that matching or histocompatibility does have an impact on both patient and allograft outcomes. So on the left of the screen, you can see that actually, the text is a bit small, but large percentage of allografts actually lost due to alloimmune phenomenon such as acute rejection, chronic rejection, and then what was known as allograft nephropathy. Today we know mainly is due to chronic ABMR. And in 2012, you can see this chart, which is familiar to all, that the long-term graft losses are still predominantly due to antibody-mediated rejection, and followed by glomerulonephritis, and with mixed rejection on the slightly lower end. And this is even more recent data in 2020, where authors looked at the causes of death with a functioning graft. And again, you could see that cardiovascular causes and malignancies and infections are the main causes of why people or our recipients die when the graft is working. However, if you look at death-censored graft survival or overall cause of graft failure, acute and chronic rejection still take a good 20% of cases. And in the USRDS report, the most recent, 2024, again looking at deaths, cause of death, many these are due to malignancies, infections, and again cardiac arrest or other cardiac causes. And so for transplant physicians, what we deal with day to day and nephrologists really is to balance out the risk of alloimmune injury, such as rejection, compared to that of infection, cancer, and cardiovascular disease. And it is proposed that this fine balance, and yesterday during the pre-congress, several speakers spoke about walking the tightrope. And indeed, I think that is what we deal with on a day-to-day basis through monitoring as well as adjustment of immunosuppression. But if we can get it right from the start, then I'll put it forward that potentially we could avoid some of these complications from occurring early. And how we evaluate the risk of sensitized alloimmune risk really, I think, goes back to this work group that's been set up, I think, called the Sensitization in Transplantation Assessment of Risk, or the STAR work group. And they actually propose a framework of looking at alloimmune risk and separate into memory and de novo. So memory risk in general refers to the risk that recipient already inherits due to sensitizing events, which for the sensitizing history, which would include generally pregnancies, blood transfusions, or previous transplant. And one way to detect it is actually through screening of donor-specific antibodies or anti-HLA antibodies. A separate category of risk is actually a primary risk or a de novo alloimmunity, which means that this usually refers to patients who do not have any sensitization history to begin with, but because of the potential mismatch with the donor organ, and they can develop antibodies or the risk of a rejection. Now, on the table on the right, again, it specifies really that the only patients who are really at a low risk are patients who have actually not had sensitizing events before. For patients who have actually a history of a sensitizing event or a detection of even non-donor specific antibodies at the time of transplant, or even at some point prior to transplant, they do have a latent potential for an alloimmune response. And of course, if you go into a transplant with a known active donor-specific antibody, then these are patients with active potential for memory response. And all this goes back to taking a detailed history in terms of identifying the sensitizing events. Usually pregnancies and transplants are easy to identify, but very often in my own practice, patients sometimes do not recall whether they have had transfusions before. And if the hospital electronic medical record system is not comprehensive enough, sometimes we may not be able to detect or identify these sensitizing events. Certain inflammatory events, such as major surgeries, major infections, or even recent vaccinations, can cause a exacerbation of a pre-existing alloimmune memory, which sometimes we do see in our clinical practice as well. Now, so when we will go on to evaluating the risk, I think this table pretty much summarizes it quite nicely in terms of how we approach a potential donor-recipient pair in terms of their risk. And again, this table does separate and differentiate between the risk of memory as well as a baseline risk for a de novo response. And so if you look at this, from this part upwards, it generally looks at memory, because there is already a history of sensitization, whereas the lower three categories will evaluate the risk of a de novo response. And so that is really just the big picture and overview. Now, and later we'll get into a little bit more about the tests involved in transplant immunology. But I think the other important part of the equation really is the resources, and I think this is particularly relevant to this talk, where we're looking at how to balance this with practicality, especially in a resource-limited setting. And I'll preface it by saying that resources are unique to every transplant and nephrology ecosystem, and this can really vary from country to country or even state to state in terms of resource availability as well as allocation. And just to have to briefly talk about some categories of resources, I think one resource that we always think about is financial. And of course, transplantation is has high upfront costs, where the cost of surgery and the cost of care in hospital is usually higher upfront. And it is not sometimes uncommon to hear in the clinic, especially where I practice, that dialysis may in fact be cheaper. And I think that really goes back to who is paying, right? I suppose in Singapore, where dialysis, 80% of dialysis is probably funded by charity. So from the payer's point of view, the patient doesn't pay as much. But when it comes to transplantation, even though there are still substantial subsidies given to patients, but the model has shifted and such that the patient probably has to pay a little bit more. And especially when they have to deal with complications such as infections, rejection, then these will also incur costs. So the cost of transplantation, again, it will be unique to each and every country. The system of payment will also be different. And so we have to probably consider in the equation who is bearing the cost. Is it the government, is it patient, or is it insurance, which I think a lot of the Western world is covered with. And so to talk about the costs or the financial cost, there will be the cost of pre-transplant evaluation, which is something that we'll focus on for this talk. Then of course there will be the cost of organ procurement, the surgeons, surgery, hospitalization. And depending on each program's protocols, risk thresholds, in terms of the risk of transplant they are willing to undertake, you have to factor in the costs of desensitization and immunosuppression. And also not to forget the long-term cost of long-term follow-up. For example, how frequently you're going to see the patient, the model of payment for outpatient care, and if they do run into problems with proteinuria or allograft dysfunction, cost of the biopsies, antibody monitoring, and even further testing. And therefore, I think this is where healthcare financing frameworks such as government subsidies will factor in and be different for each country as well. Now, besides money, other resources that may not be apparent to maybe the patient is actually that of the infrastructure. Now, to do a transplant, the transplant center will need operating theaters. You will need dialysis beds, especially before transplant and also in the event of delayed graft function. You have to think about whether you have a capacity for transplant beds, intensive care, or high dependency after surgery, and also the support for adjunct therapeutics such as the blood bank, blood transfusions, as well as apheresis if you are dealing with potential antibody-mediated rejection. And I think more importantly is the lab support in terms of histocompatibility and immunogenetics, the turnaround time of your tests, as well as the expertise to support with interpretation, as well as clinical consultation for the histocompatibility test that we send out. And also, if you're going to do biopsy, then the pathology support becomes equally important. And so you need the whole ecosystem, especially the hospital administration support, as well as a multidisciplinary collaboration, because in transplant, you not only deal with the nephrology itself, but infectious diseases, cardiovascular disease, and so a whole system needs to be set up in terms of resources. And also, I think for lab support, the collaboration and service agreements with partner institutions or the laboratories will be especially important in terms of running the tests, as well as the cost of the tests. And I think finally, we also should remember when we talk about resources in the broadest sense, are the resources actually that will be required if and when the allograft fails. Because once a transplant fails, it doesn't just end there. We need to transit the patient back to dialysis. And again, then the cost of dialysis will come into the picture, the infrastructure and the facilities required for dialysis in each country. And not to forget the healthcare burden associated with going back on dialysis, and as well as the disability-adjusted life years in terms of the patient's productivity, quality of life, and so forth. And so I think it comes for us to strive towards potentially a goal or an aim that we maybe alluded to yesterday at the pre-Congress talks as well, that is it possible to have a kidney for life? And this is actually what the National Kidney Registry in the United States aims to achieve in terms of a huge registry where patients can go on registry to get ideal and optimal matches such that you reap the benefits of having a reduced risk of de novo antibodies, a low risk of rejection, a low risk of graft failure, and you can safely reduce immunosuppression and have fewer side effects of this immunosuppression. And I think generally that's the goal. But of course, all this will take some form of resources, which we'll try to balance it and discuss it in the slides below. So just a quick overview again of the histocompatibility tools that are available to us, and to compare how they do against each other as well as the costs. Right, so I think in general, most of us will be familiar with some of the tests here, the CDC cross-match, the flow cross-match, the single engine beats, as well as the HLA typing, for which we can derive and calculate the molecular mismatch. And so I think CDC is familiar to us all, and it's first discovered by Paul Terasaki. What you do is they usually take recipient serum and incubate it with the donor lymphocytes and add complement. And so straight away you can see whether there's actually, assess the risk of hyperacute rejection on table. So I think in general most centers will not try to cross a CDC cross-match positive transplant, especially if it's T positive. Now, so it's, in terms of the tests or properties, it's it's sensitive to some extent in ruling out the risk or evaluating the risk of hyperacute rejection. Interpretation, probably straightforward. I mean, you can give a dilution factor like 1:4, 1:8, and the cost is generally cheaper to run. Okay, and I think most centers, even with limited resources, will be able to do a CDC. Now, I think the next level is enhanced CDC with AHG. And in this case, we actually just add anti-human globulin to increase the sensitivity of the test so that even when you have a lower titers or lower levels of antibodies, you can still detect it. And in terms of the cost, I think it's probably not much more expensive than the unmodified or unenhanced CDC. It does increase your sensitivity by a tad, and in terms of interpretation, it's the same way. You usually go by 1:2, 1:4, 1:8, positive, negative. Now, the next improvement is actually that of a flow cross-match, where in the same principle, you use a recipient serum added donor lymphocytes, but you do add a fluorescent antibody, and then you put into a flow cytometer, and you look at the channel shifts. Now, the advantages of a flow cross-match is really that it increases the sensitivity by quite a bit. There is a little bit of additional, I think, skill set required, at least from the lab's point of view, to adjust like the gating, the channel shifts. But of course, because of the equipment needed, the cost goes up by quite a bit. Now, I think just a ballpark figure in terms of the MFI of antibodies that can be detected, I think yesterday we also discussed in general, for a CDC cross-match, your antibodies need to be probably at least an MFI of 10,000 at the ballpark, sometimes a bit lower, 8,000, and sometimes higher, 12, 13,000. But I think for a flow cross-match, you can probably detect MFIs down to maybe about 3,000 to 4,000. So it does actually help to increase the sensitivity of the test by quite a bit and allow us to detect even kind of a lower MFI antibodies. And again, I hesitate to use strength because at the end of the day, MFI is a semi-quantitative assay. And I think studies have really shown that it is important to know that a flow cross-match is really quite predictive of outcomes in the sense that even if you have a DSA, but if your flow cross-match is negative, you will have similar allograft survival up to about a median of 4.2 years. And I think that is where a lot of countries, especially those centers who can afford the flow cross-match, will try to use the flow cross-match as a cutoff for whether to proceed or not. And in fact, I think for many centers, maybe in the Western world, they may have stopped doing CDC because it really doesn't give any additional information compared to a flow, especially. I mean, it does tell, because both can tell you whether it's complement binding or not. But I think in the sense that in this case, the flow is a lot more sensitive and it's easier to make a decision whether to proceed with the transplant or not. So that's really the most functional test which helps us to decide whether to proceed or not. The other part of evaluation is really of antibody evaluation, for which I think there are two types of tests. I think the first really is the panel reactive antibodies, where you have multiple antigens conjugated into a bead and you just run it. So again, this is a cheaper test to do. It will give you a sense of a desensitization of a patient, although it will not give you the exact reactivities against which particular antigens that the patient has antibodies against. We generally use this really as a screen for just to see whether the patient is sensitized or has any pre-existing antibodies or not. And I think most places will now actually, if they could do the single antigen beads, where you do have each individual bead is coated with one individual antigen, which helps us to identify exactly which allele or which antigen the patient has antibody against. It's again very sensitive in the sense that it can detect most antigens down to the allele level. However, there are a lot of nuances in terms of interpretation required, and also the cost is higher than that of the other tests earlier alluded to. Okay, just a brief word about molecular mismatch because it has something to do with HLA typing. Now, I think many countries will still go by typing at 6 loci at low to intermediate resolution ABDR. And with that alone, it's a little bit difficult to implement molecular matching or mismatching. Well, essentially the concept of molecular mismatching is that although you have antigen mismatch, but not the whole antigen is actually immunogenic. There are really just a couple of amino acids which are different, which are polymorphic, and which may potentially elicit the immune response, which we frequently allude to as the epitope or the applet. And here it demonstrates that for anyone or any mismatch who are one antigen mismatch, the applet mismatch load can be vastly different. For example, in this case, these two molecules which are different only has one applet mismatch, or two applet mismatch, whereas these two molecules here actually have 22 applet mismatches, which and suggests that this mismatch is a lot more dangerous, a lot more potentially pathogenic compared to the other mismatch. And to do this, we actually do need a high resolution typing at ideally all 11 loci, if not at least AB, C, DR, and DQ. And this will be where the cost of the typing is. So, and again, in this graph, it can show that actually for each one or two antigen mismatches, there can be a whole variety and a very diverse number of applet mismatches. And so this is really one way that's proposed to increase the precision of transplant matching as a whole. Now, so how do we balance precision and practicality? And maybe here at this point, we'll try to suggest a practical approach. Now, we may always ask, why are there so many tests? Right? With more tests that you do, then it costs more money. And I mean, everybody needs money, and money is always a constraint in most systems. And I think the reason mainly is because each test has its own purpose and has its own limitations. A test doesn't tell you everything about it. And so I think it goes back to this analogy of many blind people trying to figure out what this animal is that they are touching, and they all have a different idea. And usually I tell my trainees that, you know, if you compare it to cardiology, because I think for some reason cardiology is easier to understand for some of the junior doctors, then it's like, why do you need an ECG, electrocardiogram, and you also need an echocardiogram, and you need a coronary angiogram? I mean, they don't tell you exactly the same thing, but they do tell you different things about the patient's cardiac status as a whole. And so it behooves us to wonder, of course, if you have the means to, then you should do all the tests, right? Because the more tests you have, the more information you have going into the transplant. But we have to, again, balance out the resources that's available to us. And again, my old professor used to tell me this, that in healthcare, there's this conundrum that we offer 3 kinds of services, right? Good, cheap, and fast, but you can only pick 2, right? So, I mean, if it's good and cheap, it won't be fast. If it's fast and good, it won't be cheap. And if it's cheap and fast, it may not be good. And so I think most of what we're doing, especially in the healthcare system, is really trying to balance beyond the continuum of how we can balance out all 3 and still achieve good outcomes for our patients at good costs or reasonable costs. Yeah, and so the aim is really to achieve optimal outcomes at reasonable costs, especially if there is a resource constraint. And so if I would highlight, probably if we are going to try to do a reasonable, lower risk or low to moderate risk transplants at good cost, we are probably really only looking at these parts which I have boxed out here. And so in these 2 boxes, generally refer to those recipients who have a low risk of primary or low risk of memory alloimmunity. As you see that anywhere below this line, these probably have a low risk of memory response, although not to say that they will have no risk of de novo response. Whereas here you are looking at a potential risk of a memory response by trying to mitigate it by certain tests that you can do to give yourself more confidence going into the transplant. Now, so I think in this case, we're probably first looking at recipient selection being key. And Again, this goes back to a philosophy of transplantation, whether you are looking at your philosophy being utility, where you want each transplant to last each patient the longest period of time, and you want to have the best outcomes in terms of a low risk of rejection and low risk of infection, versus whether you want to adopt a philosophy of equity, where everybody should deserve a good chance at transplantation, maybe just based on wait time or maybe based on their age. However, we do know that if we're going to go into equity approach, we will have to sacrifice or at least compromise potentially in terms of the long-term allograft outcomes, unless we spend the resources to try to reduce this risk of going. So I suppose if you're looking at disease donors, if you want to go with low-risk transplants, then for the first pick, you may want to prioritize unsensitized patients, because in this case, the risk of a memory is close to zero, right? And so I may be comfortable proceeding with just a negative CDC and AHG cross-match, knowing that it will most likely be negative if you can get a good history, that the patient has never had transfusions before, you know that the patient never had a transplant, and usually if the patient is male or an unsensitized female. So I think this is the easiest cut to go with. Generally, you'll be safe, and probably you could go ahead. If you have the extra resources, you can do the PRA or even the single engine beat after that. The tricky part comes when you have sensitized recipients, right? Because of the potential and the latent possibility of memory response, even if you have a negative panel reactive antibody plus a negative AHG cross-match, it really doesn't fully exclude the potential for memory response after the transplant. And you can, as an adjunct, if you have resources, you can throw in the flow cross-match with and without the single engine beats. And so that if your single engine beat is negative and if your flow cross-match is negative, it will probably give you reasonable confidence to know that at least in the immediate or the short term, you are less likely to run into problems. But again, if let's say it's not foolproof, for living donors, again, if they're unsensitized recipients, it's probably not much different. But I think generally we would caution, especially if you are considering a husband to wife or a child to mother kind of transplant due to the potential risk of a repeat mismatch, or as in the mismatch, the DSA that the recipient will develop against is usually precisely due to the father or the children's HLA. And so in this case, probably we will not go ahead without a flow cross-match or without single engine beats. And just to illustrate one case example where sometimes even with a negative flow cross-match or a negative single engine beat in a sensitized recipient, this is actually the histogram of recipient pre-transplant. I mean, there is a very nice BW4 pattern, a lot of B antibodies, even though they're all very low MFIs. And so I think in this case, the team proceeded with the transplant. But at post-op day 7, you can see that the same antibodies actually were all upregulated to, I think, 20,000 MFIs. And this is despite having a negative flow cross-match and negative single-engine beats at the time of transplant. So the potential for memory is really something that we should take very seriously. And therefore, sometimes even with all your tools going in, things can happen as well. Right, so I guess just to emphasize the point again that only patients without sensitizing events may be considered to be immunologically low risk for albumin memory. And I suppose if the resources are really very limited and the philosophy is really to optimize your post-transplant outcomes with a utilitarian approach, then this might be the type of patients that you consider. And all other patients should be categorized as having latent potential or active potential. Not to say that we cannot proceed with these transplants, it's just that without further adjunct and additional testing, it's very much going in, I think, semi-blind in the sense that we don't really know where we are headed towards and what's the risk. Well, are there alternatives? I suppose, how about the kidney paired exchange? And again, there's no foolproof without HLA typing, for example, and usually you need 11 loci because you can be well matched or fully matched at ABDR, but you could be mismatched at DQ and DP or even C. And the fact that if you don't have a single engine beat profile going in, you never know whether there are preformed donor-specific antibodies in this sense. But is this something that can be considered? I suppose it's something to think. Let's say if it's might better to get a 6 out of 6 match on a paired exchange registry compared to a high risk transplant with going in with the DSA. So again, this is something that each system has to think about, and again, the question of resources will come into the equation. Now, the next part we'll talk a little bit about the reducing risk of primary alloimmune response, and I think this is where the matching comes in. And so the impact of ABDR matching has been exhibited or demonstrated in very early studies, and this is in 1998, where the more mismatches you have, the worse your allograft survival. And this is whether you look at only A and B, DR, or all 6 loci. And this study also showed that with every increasing mismatch, you will have high relative risk of allograft failure. But what is interesting, and actually this was identified by Tom Starzl as early as 1990, that he observed that close matching for transplantation is difficult to achieve, and that's everybody's experience here as well. And however, lesser degrees of matching have not actually correlated well with outcomes, at least on an individual level. And he actually questioned whether expensive efforts at matching should continue to become a matter of public policy, because increasing use of the tissue matching as the overriding determinant of diseased kidney transplantation nationally may or may not be equitable. And he actually observed this paradox where you have registry studies which all show this effect of HLA matching on outcomes. However, if you look at single center or even consortiums which contribute to these data pools, they cannot actually see this within their own center data. And probably it's probably multifactorial in the sense that matching is only one determinant of graft survival, and then you have your other things like cardiovascular disease, infections, which also impacts on long-term graft outcomes. And so it was his view then that HLA matching has faded as a factor in transplantation, because with modern immunosuppression, going beyond azathioprine and cyclosporine, with now inductions, acrolimus, CellCept or mycophenolate, even 6 out of 6 mismatches can have very good outcomes compared to well-matched blood relatives. And so I think that we now want to highlight really the importance of DQ, which I think many centers outside the Western world has not considered in the allocation algorithms, where I think in this UK study by Michelle Wilcombe published about a decade ago, it does show that the pathogenic effects of DQ DSAs are actually significant, where if you have a DQ DSA, definitely you fare worse in terms of ABMR-free survival, transplant glomerulopathy, as well as allograft survival. And this Australian study also showed instead of a DSA, they looked at mismatches at get-go, and if you have more mismatches for DQ, you will also fare worse in terms of your graft outcomes. And more recently, in conjunction with the Manitoba group, we actually looked at, in terms of DQ alpha and beta matching using high resolution typing. And again, it shows that with every mismatch, you do fare worse in terms of DQ mismatches. And so we go on to whether we can have a better way or more precise way of looking at the risk of alloimmunity, primary alloimmunity. And I think this study by Chris Weeb, and we validated in our own Southeast Asian cohort, where we looked at using molecular mismatch, we categorized patients in low, intermediate, and high risk. And we can show that actually if you are high risk, you do have much worse de novo DSA-free survival, TCMR-free survival, as well as ABMR-free survival. And this is the same in our own local cohort, where actually 60 or 70% of our patients were on cyclosporine. And so this can be applied across different cohorts as well. And we talk about resources. How does this actually help us? So it's been proposed that actually if you are at low alloimmune risk, you could actually reduce post-transplant antibody testing because assuming that your patient is adherent, you don't have low levels, and there is no allograft dysfunction, the risk of having a de novo DSA, especially if you're at low risk, is actually pretty low over the next 7 to 10 years. So in this model, currently The Western centers will do very frequent antibody testing for surveillance, and it amounts to about 1,200 tests over 108 months. But if we implement a surveillance strategy that is tailored or tapered, or tailored according to the alloimmune risk, you can actually save about 700 tests over the same period of time if we can get the alloimmune risk right. Now, I guess the question is, NGS testing is expensive, right, compared to using SSO or SSP testing. And so I think what we looked at was whether we could use imputation to get two field typing such that we can calculate the molecular mismatch. Well, the Western studies have shown that yes, especially in non-Caucasian groups, the concurrence or the imputation is not quite accurate, especially if you're not Caucasian. And this is also proven, I think, this study where you can actually see that if it's Caucasian, overall, the chance of getting your imputation right is better compared to if you're Hispanic or Asian, for example. Well, so we wanted to look at our own data because, I mean, we started off using only NGS in the last 2 years, whereas in the past, we were still mostly using SSP for our method of HLA typing. And so what we did was we backed imputed. So from our 50 patients the last maybe 2 years who had NGS typing, we tried to derive. We back imputed back to one field typing and then impute two field typing using the United States stats database. And we did actually find that yes, although for each race there's a varying degree of concordance for the imputed and NGS alleles. Some loci are better, generally about 80%, but the DR beta 345 is a bit lower. But if you look at the molecular mismatch analysis, in terms of applet mismatch, they're all within 0 to 1 or 1 to 2 differences. And I think more importantly, if we apply the thresholds for alloimmunity, 24 plus 39 plus 27, a good 80% of them actually stayed within the same categories of alloimmune risk, with only 6% being changed from low to intermediate and 4% from high to intermediate, which means that nobody actually changes from a low to a high risk group. And so potentially we could say that if we are able to impute with reliable registry HLA typing, which I think each country will have to have their own databases, we could potentially use this as a surrogate marker for the risk of primary alloimmunity, even for historical cohorts without the NGS typing. And so just to summarize in the last couple of minutes, I think the message really is that precision means really getting it right. And I think that's really quite crucial for optimal post-transplant allograft and patient outcomes. And, but usually this will come at a cost, resources will be required, and the availability, allocation, utilization, and challenges are pretty unique to each country and transplant unit. I think that's something that each unit will have to figure out in terms of their risk threshold. So I think if you are starting out and you want to just do low-risk transplants and have each transplant last the longest for each patient, then yeah, you probably go with unsensitized patients and maybe proceed with a negative HG cross-match, and if you can, a flow. But if you want to get it, offer more patients access to transplantation and to ensure that outcomes are ideal, then you will proceed to higher risk transplants, but that will mean that you will also probably invest more resources in more detailed and more comprehensive testing and potentially even surveillance. Of course, some of these approaches, like molecular may help to modulate or to individualize your approaches to both monitoring and immunosuppression. And there's been a lot of advances in histocompatibility tools which help us to increase precision of risk assessment, but these do come at a cost. And I think this is also where we want to work with organizations and labs so that potentially if you increase volume, the costs, there may be more bargaining power to reduce costs. And I think one message we hope to impress on everyone here is that there's really a difference between the risk of memory and primary alloimmunity. And so I suppose where in a resource limited setting, we may want to avoid the risk of memory alloimmunity because of the risks of early complications, as both infections and rejection. And there are some tools available to reduce these risks. And I think finally, I think each transplant ecosystem will have to kind of balance that approach between utility versus the equity, such that our patients will eventually have the best outcomes. And so thank you for your time. Just a short pitch that in Singapore, we're going to have a transplant colloquium next year, 8th to 9th May. This will be a hybrid format. So if you are available and if you can, do come by Singapore to visit and just to see the city. But otherwise, there will always also be an on virtual option, and we do hope to see you there as well. The website is here. Registration will be open probably in the next couple of weeks to months. With that, thank you for your time, and I'm not sure whether we have time for questions or later. Okay, well, we'll leave questions for later. Thank you.
Thank you very much, Dr. Emmett Wong, for the excellent presentation. That was very informative, and he covered most of the areas related to his topic. We have about 6 more minutes for the questions. Dr. Wong, can I? Yeah. Okay, I have one question. If you encounter any CDC positive crossmatch with IgM for the first time in a patient who has never had a history of antibodies during the crossmatches, how do you proceed?
So just to clarify, it's a positive CDC crossmatch?
Yeah, positive only with IgM for the first time, but previous antibody testing and everything negative.
It's only IgM, so I suppose the DTT treated should be negative. Yeah, because so I guess in our practice in our lab, the CDC crossmatch comes as a set of 6 tests. We have the CDC-T, CDC-B, the DTT treated TMB, and the AHG TMB. And so with that, I suppose, package or series of tests, we can really straight away know whether it's an IgM or IgG, and whether there are low levels of even IgG that's available. And so, and at least for living donors, we will always do a single antigen beat and flow cross-match as well for correlation. But if it's DTT treated and it's a negative and showing there's IgM, then we are quite happy to proceed at no additional risk. Yeah. Then of course we do have the luxury of doing the single antigen beat, and that will confirm whether it's there's any IgG antibodies that the recipient has.
Yeah, in certain places, they wait for 2 weeks and repeat the test for the class switching of the IgM antibody, whether it is happening. Unless there is the transformation of IgM to IgG, they proceed with the transplant. If there is class switching, then to detect that, usually they do the PRA, or ideally the single antigen beat testing, because that is the most sensitive to detect early development of IgG antibodies.
Okay, thanks for that, Zab. So I think in our living donor program, all our donor recipient pairs will get testing twice, usually at the first point of evaluation and again 1 week before the transplant. So I think that also gives us reasonable confidence that the first test and the second test should be coherent. And of course, if in between during the time of evaluation, if there are any new events that happen, like they get hospitalized, they get a transfusion, then we have to reinterpret all those tests in the context of any intervening events that occurred.
Thank you, Dr. Wong, very well brought out. But the point that we do take home is that the cost of testing, cost of resolving the antibodies definitely goes up with the level of sensitization of the patient pre-transplant. So we've got to understand that the antibodies need to be resolved. And while we are still struggling with a commercially available method and test for testing for memory, which is not there available, we need to just put various tests together to get the right answers as far as transplant is concerned. So if there's anybody who has a comment or a question, please, we have 2 minutes to go. So with that, thank you so much for a wonderful talk.